Welcome to our kidney session on dialysis treatment options. We have with us today Dr. Chris Agbo, and we'll be discussing this very important topic. So, if you're watching right now, I would ask you to, if you have a question you want to ask, just put your question in the chat or in the question and answer area. We would see it and we'll pick it up. He is one of the consultants at Itchinbrook Hospital NHS Trust, and he is a consultant of renal and acute medicine. So thank you, Dr. Chris, for coming on today. So before we go on to discuss this very important topic about dialysis treatment options, let's talk about what causes a person to become in need of dialysis.
Thank you very much and welcome everyone on this show today. We are looking at people that have kidney problem, and plus we have different kind of kidney problems. So at the point we're talking about dialysis, we are looking at people that have got chronic kidney disease, and we do know that they have different stages. And when we get to a certain level, at that point, it becomes very important that without what we call renal replacement therapy, the person might not survive without such. And that's what we talk about dialysis. Dialysis is one of the renal replacement therapy. What it means that without the patient being on that, it's not likely that the patient will survive any further. So those are the what makes someone to think of being on dialysis. So if you have chronic kidney disease, especially when it gets to stage 5, we do have stage 1 to 5, and the
Yeah,
5 is the lowest. And
yeah,
that's when we're now thinking that without that, we're talking about end-stage renal disease. And what that means is that without some form of renal replacement therapy, the person cannot survive.
yeah.
So that's what makes one have need for dialysis. And then we're looking at today, we're going to be talking about dialysis and then the dialysis options.
Yes. So basically, what are the different areas? You mentioned the stages. So at what point are people, so that people will understand, at what point should they be referred to the doctors? I know, that the 5 stages. So what are the stages? What are the kidney functions or the percentage of the kidney functions that will start saying, oh, about this time we should be referring the person on?
Well, we have stage 1 to 5, but
Yeah.
even at that, there's some causes of kidney problem that they don't have to get to certain stage to be
Yeah.
referred. We expect that if one has been found to have a problem with their kidneys,
Yeah.
either by doing a regular blood test or doing a urine test that show that they have protein in their blood,
Yeah.
protein or blood in their urine, they should be referred to the specialist. It's the specialist that will actually now investigate
Yeah.
to find out the cause of the kidney problem.
Yeah.
It's a possibility that your kidney function is normal, which of course, if you are looking at the percentage function, it could still be above 90%, which is what we expect as normal, and that would be stage 1. But you're leaking some protein in your urine,
Yes.
which means that you have an underlying kidney problem, which
Okay.
needs to be treated before you get to start affecting the function. So
Okay.
what we're looking at different aspects of kidney disease. Those ones that have actually started affecting the function, which we assess the function by doing what we call the GFR, which
Yeah.
estimates that, and that stages it. But then there are some that, even though they have normal kidney function, but there's some intrinsic problem with the kidneys, either that they're leaking protein in the urine or leaking blood, and those need to be investigated to find out the underlying kidney problem and treat it before it starts impacting on the function. So for the staging, we have stage 1 to 5, and then the stage 1 is anything above 90. Of course, we're just looking at, let's say, look at like percentage of
Yes.
kidney function, which is estimated.
Yes.
That is between the that's stage 1. But for this, is assume that that person is pretty normal, but then he has some possible underlying kidney problem, like if the
Okay.
person is taking protein or having blood in the urine. Then we have the stage 2. Stage 2, of course, we're looking at the stage 2, which is between the percentage of 60 to 89. Then we have the stage 3. The stage 3 is now divided into 3A and 3B, depending on the involvement of other proof, like the person is passing protein in the urine or not. But
Yeah.
we have stage 3, which is from 30 to 59. And then between 15 and 29 is stage 4.
Yeah.
At that point, we expect that everyone at the level of stage 4, regardless of what the kidney problem is, should be under the nephrologist already.
Okay.
So those ones with stage 1, if they are lacking protein, they would have been seen by a nephrologist. So
Okay.
if anyone has been discovered that, oh, he has a kidney dysfunction, maybe they've gone to the GP and done a blood test and they say, oh, their kidneys are not functioning well. At
Yeah.
that point, they should refer to a nephrologist.
Yeah.
The specialist will now investigate and find out the cause of the kidney problem in the first place.
Hmm.
Once we establish, oh, this is caused by diabetes or this is caused by hypertension,
Yeah.
we now monitor it. And if it's stable enough, we can say, okay, you can go back to your doctor and monitor it. If things deteriorate, get back to us. But any form of kidney dysfunction should be referred to the nephrology in the first instance, especially among young people, before we can actually start saying, okay, which one should go to a nephrologist or not. So we can establish, oh, this is stable chronic kidney disease stage 2. You can go back to to the GP to monitor that. But you shouldn't I wouldn't advise that GPs will decide that. So they have to refer the person first to the nephrologist, and then the nephrologist will assess if you need to do a biopsy to establish what is the cause of the kidney problem.
Yeah.
Then once that is under control, there are some of them that will need specific treatment. So
Yeah.
then you can ask, okay, we might carry on with that until we just make sure that we establish what the cause of the kidney problem is. If it's something that is reversible, we give the treatment and expect that improvement. And we also plan to slow down the progression of the kidney disease. So we don't want it to progress to stage 5 at any time.
Okay.
So those are the kind of, so I wouldn't say that there's a specific target, but of course we have what we call the CKD guideline for the GPs, so they know at what point they should be referring a patient to the specialist. Yeah.
Okay. Okay. Wonderful. So what type of assessments are done in the hospital for the patients? Can you actually touch on that?
Okay, so we always encourage people to get involved, especially if you've been told that you have a kidney problem. You need to
Yeah.
make sure that you expect to see a specialist as early as possible, because
Yeah.
one of the things that we'll find out that early referral to the specialist has a lot of advantages, because some people, when they're coming to us, are already getting close to starting dialysis, which is already
Okay.
stage 5 and
Yeah.
not good, because most of the time we'll find out that the ones that I referred earlier do better in terms of the outcome. And
Yeah.
then we're able to actually slow down the progression of the disease. But once we've established that, we assess what the causes are, and if we've been able to establish that, then we can help to slow down the progression of the disease. So if we are seeing the person at the stage 2, we
Yeah.
want that to be at stage 2 as long as we possibly can.
Yeah.
And then some of the things we'll be assessing in terms of blood pressure control, if the person is diabetic, making sure they have a good glycemic control, blood sugar control.
Yeah.
These are some of the things that will affect the progression of the kidney disease. And then the lipid control to prevent cardiovascular risk. Those are some specific things that we can do at that early stage to
Yeah.
prevent the progression, well, to slow down the progression of the kidney disease to
Okay.
the point of requiring dialysis. And of course, we treating some other complications that will come in, like anemia, because we know that kidneys has a lot of work it does in the body. One of those is producing blood. And then once the kidney function is declining, the person will start producing less blood in the system. So we also
Mm,
manage that as part of the complication.
okay.
So those are some of the things. And then in terms of when that is progressing to the level of requiring dialysis, you
Yeah.
have a planned program where you can now start talking about that, the stages, how you're going to progress from the stage you are now to the next level, which will be
Yeah.
requiring dialysis. So
Mm,
those are some of the things we assess when we're seeing patients in the clinic, especially those ones that are progressing to stage already in stage 5,
mm,
requiring, looking into that area. But for the earlier ones, what we tend to do is to see how we can control or slow down the progression of the kidney disease as
yeah.
long as we possibly can.
Okay.
And then, of course, we treat the complication as they come along, bone diseases, anemia, blood pressure control, and some of them struggle with fluid management. So those are some
Yeah.
of the we also talk about. And then dietary intervention is also
Yes.
important. So
Yes.
these are a whole lot of things that we assess when we see our patient in the clinic. And then apart from that, we also look at other comorbidities, like the patient might have other problems that will be affecting the kidneys, like some patients will have heart problems that
Yeah.
have been put on some medication for the heart that improve the heart, but they're not good for the kidneys, and that will make the kidney to get worse quickly. So those are some of the things we keep on assessing the patient as they come in contact with us to make sure that their condition have not changed. They might have other medical condition that is also indirectly affecting the kidney. So
Mm.
that way we're monitoring that and making sure that their kidney function remains very stable.
Okay.
So,
Wonderful. Yeah. Okay. That's a lot of information for people to digest, but I hope that, if you're watching right now, you're following this. If you have any questions, please just pop it in the chat. We can see it, either in the chat or in the questions and answer. We'll pick them up. Okay. So what are the two main types of dialysis methods? Because usually when a patient is referred and you've done all the assessments and everything, they get to that stage 5 where they need dialysis. And most times, doctors usually would put the decision at the patient's doorstep and say, what do you want to do? I can understand why they're doing that. I hope you can touch on that as well, why it's being done that way, because most times people don't have a clue of what methods to go with. And I was in that position myself. By the way, everybody, I'm a kidney patient, although I've got a transplant now. So Crystal, can you just tell us really, why doctors, number one, put the decision at the patient's doorstep? That's the first question. And then what are the two main types of dialysis methods, and what should patients be considering?
okay, thank you very much. So I think we in our practice in the NHS we high standard is the key, and of course, patient-centered care is the motto. So most of the time, we're not putting the question back to the patient. We just kind of involve the patient in decision making, which
Okay.
is what we call the shared decision making
Yeah.
approach model,
Mhm.
which is what we use. We
Yeah.
don't use the hierarchical kind of approach where you just say, okay, I'm the doctor, this is what I want you to do. We don't do that in the UK. We practice high quality care.
Yeah.
So what it means that anything you're doing, regardless whether it's dialysis or any form of treatment you're giving to your patient, you have to involve the patient in that decision making. Having said that, it doesn't necessarily mean that the patient will say, oh, okay, I want this, when you know that that's not the best for the patient. You're going
Okay.
to sit down with the patient, discuss, involve the patient in the decision making. That's what we call it. It's actually involving the patient, it's not putting the patient at a spot to make the decision itself, but actually involving the patient in decision making. And for us to do that, we have to give them adequate information so that they can understand what they're going into. They can say, okay, I think about this one. I would prefer this, or what do you think? So it's like getting, so it's not just giving the patient, okay, you decide. But before we do that, we just need to get the person involved to understand what the person is going into. And that is what we call shared care approach. So we're just allowing the patient to be involved in the decision making of their care, which evidence has shown that it helps significantly in improving the outcome. So
So,
going
so
back to,
sorry,
yeah,
just very quickly. So, because you said something, I need to clarify because in my head I'm trying to think it through. So, how do you identify the best methods for a patient? Because you just mentioned that. So it's shared decision making. But how do you identify that for a particular patient? Because there's so many patients. So how
yes.
can you do that?
So we
Yeah.
have individualized, so it's personalized care. So
Yeah.
every patient is seen at different, because each patient has got their own circumstances. So if I'm looking at a particular patient, I probably would have known the patient in and out and known all the medical problems, known the pros and cons. The patient might not actually have the understanding, but
Yeah.
as an expert, you should be able to say, oh, because of ABC, using this one might not be beneficial to you. So you're
Okay.
actually narrowing it down to that individual patient himself that you're seeing right in front of you, not just the generic, these are the pros and cons of this particular method, you decide. But I'm going to say, okay, I've actually seen this patient. I know you've had transplant twice now. This is your second. And then I'm looking at that individual patient and that circumstances, and I'll bring up the best option and say, okay, these are the options. I'm considering your circumstances. this is what I think might be better for you. So that's how we make that decision on individual basis. Even though there, of course, there's a standard, but we always kind of review every case by case and then look at their different comorbidity, their circumstances,
Yeah.
every other thing that needs to, which we're going to talk about later on in the
Okay.
course of this discussion.
Okay, so just following up from that,
Yeah.
so do you actually do doctors actually support transplant first before dialysis options? Because I don't know why most people are actually referred onto dialysis straight away rather than transplant first, which is a better method of avoiding going on dialysis, which actually brings on other issues with them. So, can you just actually expand on that for people who are listening or people who are watching the replay so that they actually understand when they're making those choices?
So yeah, so the gold standard, because we are talking on dialysis at this point, we've not touched on transplant. So
Yes.
transplant is one of the renal replacement therapy.
Yeah.
Dialysis and transplantation. Transplantation is the gold standard, but we expect that that person will regain normal kidney function if everything
Yeah.
is part of it, works well. So for us, every patient that gets to the level of CKD stage 5,
Yeah.
we should be discussing about transplant. And at that point, that's when we are working the patient to be on the transplant waiting list, which
Okay.
is the national waiting list in the
Mhm.
country. And
Yeah.
for those ones that have potential for live donors, we also start talking about that. We encourage preemptive transplantation. That is very
Mhm.
much a practice. So we
Yeah.
encourage preemptive transplantation. Having said that, it's not all the case that you have people that have live donors, people that will come up to donate and all that. But even at that, with the waiting list in the transfer by before the person starts dialysis, if we suspect that the person should be going on dialysis within a year, we
Yeah.
should be working up to put the person on a waiting list within that period. So that is something that we encourage so very much so, and it's the practice. So the first thing is preemptive transplantation if we can, but
Mm.
other cases where we cannot, we have to progress to say, okay, how do we continue with that while we're waiting for the transplants?
Yeah. Okay. Wonderful. Thank you very much. So now down to the dialysis options. I will allow you
Great.
to talk on that now.
Yeah. So coming to dialysis option, we have broadly two types of dialysis options, and then in that too, there are also some kind of different types. So we're
Yes.
just going to try as much as possible to put in a very simplified way.
Yes.
So we do know that the kidneys, when they are working, the kidneys, what the dialysis does is just trying to do a part of what the kidney does.
Yes.
So we can't read dialysis is not just we can't treat it. It can't work as a function of the kidney because the other things that the kidneys are doing that the dialysis cannot do. So it's just doing a bit of what the kidney does, which is the excretory function. So
Yeah.
we have the hemodialysis and we have the peritoneal dialysis.
Yeah.
So hemodialysis, of course, hemo means blood, and the dialysis is just exchange of
What?
substance from one place to the other.
Okay.
So then the peritoneal dialysis means bowel. So peritoneal is just the lining of the bowel. So
Mhm.
what covers the bowel like a membrane, it's just
Yes.
like what do you call it now? A barrier within the bowel and the outside. So
Yes.
that is what we call peritoneal dialysis. So there are two types. The one that is hemodialysis is the one that is you're connected to a machine, which is called a dialysis machine. And what the dialysis machine is produced in such a way that it looks like kidneys. So
Yes.
the same way the kidney works and all that. So what we do is to connect the patient to the machine,
Yeah.
and then the patient's blood will be taken out from the body and goes into the machine and goes round the same way the kidney is done, the way kidney does it in the body, and
Yeah.
then takes it back again, and it continues over and over again for 4 to 4 hours. That is what we call hemodialysis. And what that does is that it takes some of the waste product out of the system as they are going through different membranes, which
Mm.
we won't go into that because it's too technical. But that
Yeah.
is the machine connecting it to the machine, and it involves being connected to either the what we call the fistula. So the fistula is just creating a bigger blood vessel that we can use to put needles and then get that through to this machine, which is
Yeah.
more permanent than or you put a line, either a neck line, a big tube, connect it to the neck and get blood out of the body to the machine and take it back to the body. So that goes on repeatedly for up to 4 hours and is done 3 times a day, so 3 times a week.
Yes.
So this is one, which is called hemodialysis. So this can be done in the center, in the hospital itself,
Yeah.
or it can be done in, we have what we call satellite units, where we have, they just a unit of dialysis unit outside, it's not linked to any hospital.
Okay.
Most of the patients that goes there are people that are very stable, that they can work there, and we don't have any issue with that because those places don't have any medical cover. So we expect that those people can work there, get
Yeah.
their dialysis done, and go home without any problem. So
Yeah.
that's the second one. Then we have the home hemodialysis. So what it means that these people have the machine at home, they connect this themselves. So it's a lot of training. So the patient can put a needle in their fistula, which is already created, or connect themselves to the tube, which is the neckline, and go through the machine and will be able to prepare the machine and all that. So it requires a lot of training. We
Yeah.
have a lot of patients that are on home hemodialysis, very convenient because they can do it at their own time and they can do it more than 3 times a week.
Yeah.
So that will be 3 types of hemodialysis we can look at.
Okay, can
Then
I just ask a question? Can anyone do home hemodialysis? Anyone at all? Because there'll be
no,
people who are very sick, there'll be people who are competent enough to do it on their own.
no,
You
no.
know,
So for you to qualify to do home hemodialysis, you will have to assess you to make sure that A, you can actually. But what we do is that those ones that we have a kind of training for those people that
yeah,
are going to home hemodialysis, and you go through the training to 3 to 6 months while you're already on dialysis in the hospital.
yeah,
And what it means that you start, because it involves a lot of, firstly, you have to prepare the machine, we have to put all the different fluids, prime the machine, and those are things, those are technical, very technical things. So it's not everybody that can do it. So what we do is that we train people, we encourage people to be part of that. So
yeah,
those people that feel that they can do it,
yeah,
we start training them. So firstly, you train them on how to even prepare the machine, know all the different function of the machine because when they are doing it at home, nobody is there. And some
yes,
alarm will be going off. You need to make sure that they're not connecting air into the blood system. So those are things that they go through a period of training before they can actually say, okay, well, and they will do it in the center a couple
yeah.
of times, being supervised before we can now say, yes, this person can do this without any
Without
problem. So it's
issue.
not everybody that can do home hemodialysis. So
Okay.
those are people that are really very motivated, that have what it takes in terms of skills because they have to connect themselves, they have to needle themselves, which is not, I can tell you that majority of the people will not be able to do that
No,
because
I can attest to that. Yes.
it's very few people that can actually, that are brave enough of their family member can do it. So
Yeah.
those are the ones. So it's not everybody that
Oh,
home hemodialysis
okay.
is for.
So
Yeah.
families can actually train to that to help their their loved ones get on the dialysis machine at home. So
Yeah.
that could be an option for those for people who are not so competent, like older people. That
Yeah.
could be an option if they have family who can help them. Yes.
Yeah, so if you have a family member who is committed, but what we're talking about is long-term commitment, not okay, I'm doing it and then because for us to set up the dialysis at home, it takes a
Yes.
lot of stuff. We have to talk about the water system, the
Yes.
electricity, and all that because this has to be factored in because the NHS has to pay for that because we don't expect the person doing that to now be coming out of their own bill.
Okay.
So
Yeah.
those are things, and we have to readjust the living environment. So it's not something it's okay. I want to start doing it, and then after 1 month, no, I can't do it. So we go through different kind of counseling, making sure that
Okay.
that family member is ready and is committed for that period of time.
Oh, I
Not
see.
after he's done it for 2 weeks, or say, you know what, I don't think I can cope with this. So those are the things that we, if he's a family member, he also
Yeah.
has to go through the training and we make sure that he also knows the level of commitment that they're getting into. So, but
Yeah.
they can also assist. Yeah.
Okay, so is it only
Yes,
one
sir.
person that will be trained or several people? Because usually, if you're having a family to come around to help somebody, they might have to go to work. So if there's somebody else who is there, would you? How many people can you train at the same time to
I
actually
think
help this person?
I think because of the training is quite intense and it involves a lot of so we train or someone has to take responsibility of that care. So we
Hmm.
can't just say okay, three people because
Yeah.
anything can go about. If the patient is saying, okay, I'm the one I'm going to train, so the patient will be certified that he has been trained and is competent to do all those. Likewise, a family member. So we can't say, okay, let's be training three people at the same time. It doesn't work. Unless if someone that has been trained, if we feel that is struggling, then we can get somebody else. But not that we want
Um,
to train so many people out because we also need to consider the human resource because these are the people that are going to be doing the training are also our staff. So they have
yes.
to get a lot of commitment to make that happen. And even while they are still at home, the nurses, those one in the community will also be going there to check on them to make sure everything is working well. Yeah.
Okay. Okay.
So that is the three aspects of the hemodialysis that we can look at. Then we talk about the peritoneal dialysis. So peritoneal dialysis is slightly different, but it's still the same kind of principle. What we're doing now, we're getting some bags of fluids, and firstly we put a tube into the tummy, which is different from the other one. The other one will connect it to the blood system through the neck or through the fistula, but this one we connect it through the tummy, make a hole in the abdomen, and pass it through the lining. So it's going to lie between what we call the peritoneal cavity. So what we do now is to get a bags of fluid, which is what we call the dialysis, and then put them into the tummy, and they sit in there for a little while. After that, we now drain them again. So what we're expecting that while they're sitting there, the peritoneal membrane, which is the lining of the tummy,
Yeah.
is also removing those wastes. When they're removing it, then we'll now, after they've done that, as they're exchanging through that membrane, they now bring them out again. So this one is continuous. So you do it, you can do three or four exchanges in a day. So what it
Okay.
means that you put this in bag in, connect it, wait for 2 hours. You're carrying this whole fluid in your tummy. You might be walking around with it. After that, you now go and empty it and put another one again and start walking around. So that one requires kind of very methodical
Yeah.
and you have to be very it has to be timely. So it's not something, it's okay, I've left this fluid in my tummy for 4 hours or 6 hours without exchanging it. So you should know when you should be exchanging the next one, you should be emptying it. So
Yeah.
because this fluid will be sitting on your tummy for few hours, then when it's due, you go and empty it and put another one and carry on with your work. So it's something that it requires a level of independence. You have to be very motivated to do it. So that's what we call the peritoneal dialysis. So you do it 4 times in a day, and it's daily. So it's not like the other one that you do 3 times a week
Yeah.
in the machine.
Okay.
Okay, and then this requires loads and loads of bags of fluid. So you don't see any blood at all. So this one, there's no blood connection at all. All you see is fluid coming into your tummy and going out.
Yeah.
Then there's another one that we call automated peritoneal dialysis, which this one we now have this fluid lined up in the piled up in a machine,
Yeah.
and then you just connect it at night, and they will be doing the whole exchange for you
So it's overnight. So it's
overnight. So
overnight.
while
Yeah.
you're sleeping, this is going on, and after in the morning, everything is emptied. So that's what we call automated peritoneal dialysis. Then
Okay.
we have the assisted peritoneal dialysis. Those ones are the ones that some of the staff are going there, help the person to do the instead of the
Oh.
person doing it itself. So those are the
Okay.
three types of peritoneal dialysis we have. So those are the kind of thing that they will be asking you, what do you want? But before they ask you what do you want, they would have taken you to the education sections where they will
Yeah.
show you the different diagrams. They will take you to the dialysis unit where the ones that are doing the machine one are there and the
Yeah.
peritoneal. So they will demonstrate all those to you before they ask you to make those decisions. But those
Okay.
are going to be centered around these 6 areas we've talked about. So you are going to be likely asked after you've gone through all those ones, which one would you prefer? And of
Okay.
course, having said that, it's also dependent on your condition. And we're going to be talking about what are the factors that will determine which one is best for you. So there are a lot of things that we also consider when we are looking at that, because not just asking you what do you want. You can say, okay, I want peritoneal dialysis, when you know that the person is not doesn't have a good eyesight. There's
Yeah.
no way you can do that. So we still do that and make sure that the person is aware of what each of those are involved. So we're going to be talking about some of the factors that we also use to assess what is best for each individual patient.
Okay. Okay. Thank you very much for that. That was quite detailed. I'm sure that whoever is watching right now, I hope that they're getting all the information they need. Again, if you're watching, you have any questions, please put them in the chat or in the question and answer section. I'm looking at the chat and I will pick the questions from there and answer them. So, my next few questions would center on these treatments you've just talked about because a lot of people are not aware about them and what the best treatment is for them. That's some of the questions we get in our charity. And when I was given, I also did peritoneal dialysis as a kidney patient. When I was given the choice initially, I couldn't think or choose. I settled on the one I felt was less painful. Goodness, was I wrong? So based on that, which of them is the best treatment for a patient to go for? Which would you
Well,
advise?
okay, well, best treatment is not, I wouldn't say which one is best treatment now. So for each of the modalities, the hemodialysis and peritoneal dialysis, evidence has shown in the first 3 to 4 years, the survival and outcome is just about the same.
Okay.
Okay. That's initial 3 to 4 years.
Yeah.
However, we don't see them as separate entity. We see them as a continuum. It's just like a pathway. You can go
Yes.
from PD to hemodialysis, from hemodialysis to PD.
PD.
But
Yeah.
so it's not okay. I'm going to be on hemodialysis, and you just say, okay, this is my team. I'm hemodialysis. I don't want to connect with no. We it's all kind of they're all different pathways. So we don't look at it from that angle that which one is best for you. So for for peritoneal dialysis, each of them has got their different. I would just kind of describe what they entail. Maybe that would be, but I wouldn't say which one is best because I'm not meant to.
Okay. Okay.
Bias.
Let me rephrase that. Let me rephrase that. So
Yeah.
let's
But
look
I'm
at
going.
the
Yeah.
advantages and disadvantages of
Yeah.
both.
So I'm
Okay.
going to.
Hemodialysis and peritoneal. Yeah.
Yeah, because there are some of my colleagues that are specialists in peritoneal dialysis. They want to
Yeah.
promote that. There are some that are specialists in hemo that they want to promote that. But we're going to look at everything in a balanced way because
Yeah.
each of them has got their shortcomings, shortfalls, and
Yes.
all that. We
Yeah.
just need to look at that. For the hemodialysis, of course, we've talked about that. It's intermittent. You go to the hospital 3 times a week,
Yeah.
4 hour dialysis, you add your transport to it. So those are the things you have to look into commitment at that aspect. For the peritoneal dialysis, the characteristic it has to is daily. So are you able to do it daily? Every day you have to be doing this bag wherever you are. If it's in the office, well, we'll get to that one. But then
Yeah.
that's continuous and you have
Yeah.
to do it or the if you are doing the one in the machine. So those are the characteristics of those ones. So people are different. Some people will look at, okay, I can do it. I think this one is more flexible for me. This is, I think I just like to know when I'm doing one. So it all depends on individual preferences. But we're
Yeah.
looking at each of every one of them. In
Yeah.
terms of the procedures, most hemodialysis are dependent on other people. Like if you are doing in-center or satellite dialysis, you have
Yes.
to depend on the
And then,
dialysis nurses
yeah.
to do everything for you and all that stuff. Unless if you are doing home hemodialysis, then you are independent, you are doing it yourself.
Yeah.
Okay. But in terms of the peritoneal dialysis, there's some level of independence. You're in charge of the whole thing.
Yeah.
It's just like the same thing like home hemodialysis. So we call them home therapy. So
Yeah.
peritoneal dialysis and home hemodialysis, we call them home therapy. So
Yeah.
those ones have some degree of independence. But then having said that, this independence is just specific. You're going to be continuous. It's like it's on a regular basis. So it's not like you're doing it just 3 times a week. So those are the things in terms of the procedures themselves. Then the other thing is that when we're looking at the traveling time, because a lot of times these are life transforming issues. When
Yeah.
you get committed to dialysis, you have to think about I'm going to be spending 6 hours 3 times a week out in the hospital.
Yeah.
So I'm putting the 6 hours because I have to add transport. The time you get to the waiting area, the
Yeah.
nurses have to call you in. So it's not just that you go in there, when you start. So
No.
actual dialysis is 4 hours, but then the all the small, the
Waiting
preparation,
time. Yes.
waiting to the dialysis, waiting for your own turn to come, for nurses to middle. So those whole thing, we're looking at give and take extra 2 hours. So we're
Yeah.
looking at committing almost 6 hours 3 times a week
Yeah.
on dialysis. So if you're a young person who is working, that's going to impact on your job.
It's
So
gonna. Yes.
those are things that we have to factor in for hemodialysis. For peritoneal dialysis, you can do them even in your office. You can quickly go to the toilet, change them, come back, continue with your work.
Yeah.
For those people that are very motivated and all that. So long as you have a place where you can store it and you can do all the exchanges and all that stuff. Do that. Come, I've had patients that are walking and they carry their bags, and when they go to the toilet and do the exchange and all, and move on with it. So, but you need to have that space.
Really?
Yes,
What about the infection rate? Because
you have
in
to,
terms
of
of
course, those kind of people have to have a space where they can do it. So
yeah,
before you do that, you have to be. We will have checked that where you're going to be doing that is safe enough, and you dedicated that place. You can't just go to any public place and start doing exchange of you.
no
No,
goodness,
it
no,
has
no,
to be a dedicated space where you have to make sure everything is sterile and all that to
yeah,
minimize infection. So which is
yeah,
important. So
yeah,
those are some of the things we also consider for people that are going into peritoneal dialysis because it involves a high level of hygiene because it takes a lot of
it
everything is
does, it does,
every single step you have to be sterile. So we need to make sure that this person. So, but those ones that have that dedicated space, they can also carry it out in the office or if they're on holiday. In
yeah,
terms of travels, so we're just looking at different aspects.
yeah,
Travel holidays for hemodialysis. If you're stuck there, a lot of times people when they're stuck there, it's a bit of challenge to travel. But if you are going to travel, we have to look for if it's within the UK, we still have to look for a dialysis unit
center, yeah,
that where they will accept you and then they'll give you a slot where you can get there. And therefore, the time they give you the slot is fixed, so you don't have any choice. Okay,
yeah,
we have this 3 p.m., so you have to be here at 3 p.m. So it doesn't matter what. So those are some of the challenges with hemodialysis. Then, if you're traveling abroad, it's also the same thing. You have to look for holiday dialysis where you can do your dialysis while you're
hmm,
abroad. That doesn't, for the fact that your dialysis period doesn't stop you from traveling, doesn't stop you from going on holiday, but it's going to be, you're going to be guided by where you go to because you can't go to anywhere where you can't have dialysis.
yeah,
Wherever you're going to, you have to make sure that you're going to have adequate dialysis. You have the facility near where you're going to. So those are the thing, but that doesn't stop you from traveling at all. But you
okay,
must have a place where you can have dialysis while on holiday. But
okay,
for the peritoneal dialysis, those ones is the PD fluid can be delivered in most part of the world. So you can arrange that they will deliver it to like if you are going to Spain or you're going to America, they can deliver it to where you're going to before you get there. So you have access to that for maybe 1 week or whatever time you're going to spend there. So those are some of the pros and cons of each
no,
of those ones.
just to ask, what about people going to Africa? Because I've had patients ask if they can travel to Africa, and that is a main issue for both for hemodialysis, and I think the main issue that some of them have is they want to go on peritoneal dialysis. So, what is your advice on that? Traveling to Africa with either hemodialysis or peritoneal dialysis?
So if you're traveling to Africa, depends on where you're going to. There are quite a number of dialysis units you can contact before you get in there. So which of course, what's happening, you have to do your research very, very well. I'm not going to mention any
Yeah,
dialysis because it's not, but you
yeah,
have to do your research very well and make sure you're going to a high quality dialysis unit and you can arrange to have your dialysis while you're there.
yeah,
But of course, when you come back, you're going to be isolated for a period of time because once you've gone outside and come back, especially
yeah.
for your dialysis period, we're going to isolate you to, then you're going to have all the screen done again because of infection, a bloodborne
Yeah.
infection from other centers and all that.
Yeah.
For peritoneal dialysis, that one is a bit more difficult in terms of delivering some of the PD fluids to some part of the country, part of Africa might be difficult. But that, having said that, is also something that if someone is already on peritoneal dialysis and have the space in Africa where you know that is, you can do that, they can also arrange for that to be delivered, which because the person is already doing it, so it will be a lot easier for the person to carry on with their peritoneal dialysis without much problem, so long as they have that PD fluid delivered. But of
Well,
course, there will be some countries in Africa that they might not be able to deliver such PD fluids. Yeah.
yes, because these are people. Some people live in rural areas,
Yeah.
so usually the dialysis fluids are delivered to the capital. I think the
Yeah.
main issue was, what if they get an infection? How how do they get treatment? That is one of the issues that people have about that. So I don't know if you have any
For
idea.
because most African countries don't have much peritoneal dialysis services, so it's usually a bit of so anyone that's on peritoneal dialysis, you have to be very careful in terms of traveling and all because one, you need to it's not something that you when you get it, it's different from hemodialysis. You have
Yeah,
more those are the ones they do more in
yeah,
most African countries. But peritoneal dialysis, a lot of the specialists they are not familiar with that, and then
yeah.
because they don't do it, even though it's something that we encourage them to start, getting involved and all that. But if you have that problem, it's going to be a challenge. So if you're on peritoneal dialysis, before you go and embark on any other, discuss with your nephrologist and your PD nurses, and they will be able to guide you in terms of where you're going to go. If you're going to be staying in a place that is well spacious and sterile and all that, you shouldn't have any problem with infection. But if you're going to be going to where you think you're going to be in a crowded area, the high rate of infection is higher. So those are the things we need to consider. But you have to discuss with your specialists regarding that. Yeah.
Well, I'm originally from Nigeria, okay, and I did go to Nigeria with my PD, and
Yeah.
I did PD. But I think mainly it was my issue was coming from a state, Edo State, that is very dusty. So no matter how much you try to make sure that your environment is clean, hygienic, and you clean, my family were cleaning every day.
Yeah.
There's that problem of dust getting in and actually getting to the site, and then you
Yeah.
get infected. Okay, yeah, I had an hospital opposite my house, so that wasn't the problem. For those people who don't have a house, who don't have their houses close to hospitals, what can they do? Because obviously people would have to travel. What can they do in the meantime before they can get to a major hospital?
So what we advise people when you're on dialysis, before you travel, we have to discuss where you're going to go.
Yeah,
We look at the risk, and then because those are specific things. Because if you develop peritoneal infection, it's quite serious,
it
and
is.
so it's quite serious. And that could even lead to your. It's very serious. So it's not something that we will encourage you to go. Okay, travel to anywhere because you've got PD. So it's not something we encourage people to travel anywhere. We're not certain that that standard is maintained. So
Yeah,
most nephrologists wouldn't advise people to just travel to a place where they know that when they get there, they're just going to get infected and all. It's
yeah,
more like sending them to a suicide mission. We wouldn't encourage that. So even though we encourage people to travel, but there's limit to where we can tell people to go to. If I
yeah,
have a peritoneal dialysis patient, I say it's going to go to a place where they don't have access to hospital or there's no point saying okay go. Though I know that going there is like you're gonna go there, get infected, and
yeah,
you might not get back here.
yeah,
So we try to discourage that. So
yeah,
we only encourage you if you are certain that there's adequate facility for that to happen where they're going to go. So for the fact that we encourage traveling doesn't mean that anybody can travel.
yeah.
So,
Okay,
so it's
okay,
important
thank
that
you.
you discuss with your specialist before you even start thinking of traveling if you're on peritoneal dialysis or hemodialysis. Yeah.
Okay. So, moving on from that, so we mentioned earlier on about diet, advising patients their diets, to keep within their condition and stuff like that. So how does the diet differ between hemodialysis and peritoneal dialysis?
Well, I wouldn't say that they differ really, apart from the fact that, of course, if you because of what we're using for the peritoneal dialysis has a lot of glucose in them. So for those people that are diabetic and all that, we tend to be very cautious with that in terms of the components of those fluids,
Yeah,
unlike the hemodialysis patient. But overall, both of them has got this kidney impairment, which a lot of the things that the kidneys are needing,
yeah,
there are a lot of things that we have what we call the potassium level because the kidney is not getting out some
okay,
salt out of the system because those are
yeah,
some of the functions they do. Even
yeah,
though you're on dialysis or you're on peritoneal dialysis or hemodialysis, there's still some dietary advice. We have what we call the renal diet, which the
yes,
dietitian would have sat down with the person before they even started dialysis. Those are some of the things that we do at the low clearance clinic. Talk about your diet. This is the whole high phosphate diet, high calcium, high potassium. These are the things you need to avoid. And those are things that are complication from kidney impairment. So
yeah,
we don't want more complication. But once we have what we call the bone diseases, it's become more complex. Or
okay,
we want to reduce the cardiovascular risk as well. So those
yeah,
are some of the things that the dietitian during the low clearance clinic pre-dialysis period would have taught the person through, and
yeah,
also the fluid balance because we a lot of time when you're on hemodialysis or peritoneal dialysis, what we're trying to do is to get the fluid out because a lot of people the kidney also help the body to maintain fluid balance. And
yeah,
once that is not working well, you find out that people are accumulating fluid. So we can easily take those off from dialysis
yeah,
and peritoneal dialysis as well. But that is dependent on how much you're also taking in. So a lot of people on dialysis, we tend to put them on fluid restriction. You find out that some people can only allowed to take 750 mils of fluid in a day, which is
yeah,
quite stringent, tight.
yeah, yeah,
So what we are doing that is just the body is trying to get rid of the fluid, and if you are consuming more, what it means that by the time you're getting to the next dialysis section, you're like drowning.
included, yes,
So those are some of the things. Those are the things that we manage effectively. So it's not just about going into dialysis. We also manage how much you drink. So we maintain a dry weight that we can target when you go on your dialysis. The same
okay,
thing with those people on peritoneal dialysis. So most times the diets are things that is not related to the level of kidney impairment, which is mostly on board. But specifically for the those ones on peritoneal dialysis, we look more closely in terms of their sugar level and because of the content of the dialysis fluid. Yeah.
okay. So in terms of the fluid restrictions, so you just talked about fluid balance. So when you say someone is on 750 mils, which is I was on 750. So is that just the drinks they have, or does that involve anything else?
Anything liquid.
Anything liquid. So in terms of cooking, soups, because obviously African diet is based on fluids because we cook our rice, we cook our yam, we cook our beans, we cook our soups, we drink soup because there's something called pepper soup. So
Yeah.
so how can people manage that? How can kidney patients manage that?
So of course, when people start dialysis, they'll start as time progresses, the kidney function, what we call the residual kidney function,
Yeah.
start dropping. So the amount of water they pass start reducing until
Yeah.
they get to a point they can't pass water at all. So
Yes.
if someone is not passing water at all, that point it should be on 750. But what it means that anything you drink, you take in can't go anywhere.
Yeah.
You have to now rely on this machine to take those things out. So that is why when we get to that point is the last limit, which is so of course when people start on dialysis, they might still be passing reasonable amount of water. So we allow them to drink more. But as we monitor the progression over time, as it goes in a few years, you find out that they start dropping and they just pass very little. And then we measure that and say, okay, we calculate how much you're allowed to drink. Because we have calculated how much weight you're adding between dialysis section. The same thing with peritoneal dialysis. Then we now decide this is how much you're allowed to take. So it's difficult, but those are some of the things that helps in the management of, and that's why patient education is important because they need to understand why those things are happening and
Yeah.
why we are telling them. We don't just want to be mean and say, oh, don't drink here. Then you think, oh, I have to drink some beer, and then the beer is even like 750. So no, you can't do that because that is you're just destroying yourself. So those are some of the things we
Yeah.
try to educate our patients so that they
Yeah.
take part of their management. That's why we talk about shared decision making. So they know what they're going into.
Yeah.
They decide about that as well. Yeah.
Okay. So, what would you advise? Because on another topic, because a lot of times patients also ask, if they can buy medicines over the counter. What's your advice to patients about over the counter medication? Can they go and buy, like, for instance, can they go and buy, different medicines over the counter? So, like aspirin and those kind of things. Would you advise that for them to do that?
So for renal patients, we do tell them that on no occasion should you self-medicate. So even when you go to hospital, let the doctors know that you're a kidney a renal patient. But a lot of time, our patients are admitted to hospital and they don't know they give them different kind of medicine. But most time they would have known that this person is a renal patient. So it's always important that they know about their medication and make sure some of those medications shouldn't be left without taking them. And you can't go to the chemist or to the pharmacist and just purchase any kind of medication, but those are not good for your kidneys. And because the kidneys are not working well, there's some medication that will not, you can't even handle at that level. So it's important that you do not self-medicate. If you have any problem, get in touch with your GP. If your GP is not clear, you can always get in touch with us and then get, but do not self-medicate. Even if you say, oh, this person used it and it helped, don't do that because you are not that person. So it's
Okay.
very important. Yeah.
Okay. What about because some Africans would they think that there are other native solutions to kidney disease. So they boil a lot of plants, fruit leaves, vegetables, and all of that, and they drink them. So something like lemongrass, mango peels, orange peels, and all of those. Someone actually mentioned once garden egg, aubergine leaves. That can they boil the leaves and drink them to help their kidney disease? So I would like to find out your professional opinion about that. Really,
Well, I think yeah, some of the things you've mentioned are not, they're just fruits and vegetables that are eaten by anybody. And what
yeah,
we encourage is healthy diet. So if you decide to take mango and instead of chewing the mango, you want to boil it, I don't really think that. But in terms of saying that it's medicinal or it's a treatment for a kidney disease, I do not think that is established. But what we encourage you is to have a healthy diet, a lot of fruits, vegetables, and of course, some of the things you have to be eating will be in line with what your renal diet allows. It's
yeah,
not every vegetable that you can eat. It's not every fruit that you can eat because of your kidneys. There are some of them that have high potassium in them, and some of them that have high phosphate. But we are giving you some medication to get those things down, so we don't want you to consume them. So a lot of time, the dietitian would have giving you a long list of the ones that you should be avoiding and the ones that have high phosphate diet and high potassium diet and the rest of
yeah,
that. So those are important. But in terms of the herbs, about the ones you've mentioned, they're kind of describe some of them as fruits and vegetables, so they're not really herbs. But the herbs, those ones there, I don't know what if they are not tested, you don't know what is their content. But the ones we if it's just like orange, lemons, and all those are things that you can drink them for anybody. It's just healthy, but that doesn't mean that it's treatment for kidney problem. A lot of time people say a lot of things, drink this amount of this and then to flush your kidneys. It doesn't work that way. Kidneys are not things that is flushed by drinking some concoction. So, and I will encourage people to seek medical or medical advice. Your pharmacist should be able to tell you what you should not be having as a kidney patient. Your GP should be able to tell you, but do not embark on, okay, somebody said that if I drink this amount of concoction 7 days for 3 months, all my problem will be solved. It might cause more problem than solving your problem.
Yeah. Okay. Thank you very much.
So I
So I
want
just,
to
yeah, go on.
look at the factors we consider when we're talking about what treatment is best for one.
Yeah.
So we just wanted to point out that because of time, so we'll just highlight that very quickly.
Yeah.
Factors that can be considered when deciding what dialysis treatment is best for the person. So we look at the age of the person is determined. That doesn't, for the fact that you're older doesn't mean that you can't have dialysis, but it also determines what kind of dialysis you're going to have. So if it's an elderly person that is frail, well, not frail, but an elderly person in a care home and all that, we probably advocate that they pop to do hospital dialysis without
Okay.
even, we can't say, okay, you come and do home hemodialysis and all. So those
Yeah.
are some of the things. For younger ones, you might want to throw those challenge of, do you mind going through the PD or home hemodialysis? But those are the ones you think can get through that. The
Yeah.
other thing, of course, we talked about eyesight. If someone that is partially blind, you don't want the person to
Yeah.
get involved with peritoneal dialysis. So
Yeah.
those are some of the specific things. And mobility. If somebody is have poor mobility and all that, you don't want the person to be fiddling with because this some of the dialysis fluid are heavy. This
Yeah.
someone that actually have that strength to carry them. Manual dexterity, if you're able to do a lot of stuff, if you have poor dexterity, it might not be, PD might not be an option for you.
Yeah.
Housing is very important. We look at housing. If you are living in a crowded place, the place that doesn't provide that room for machine, for a hygienic condition, it might not be considered for peritoneal dialysis or home hemodialysis. So those are some of the, and then we also look at family or social support if
Yeah.
you are requiring those. So there are a whole lot of things that we look at. And some people, because of their work, we consider them, okay, this person is working in a bank. How do you know? You just have to look at individual cases and say, okay, which one do you want to consider this? This might give you some level of independence. And then we talk about other medical problems that might be militating against you having one or the other.
Yeah.
Compliance is important because if you're not compliant with your medication pre-dialysis, we already know where you're heading to. Because if somebody is not adhering to medication, I'm not sure I'll be comfortable that the person can go home and do peritoneal dialysis all by themselves. So
No.
those who are already non-compliant before dialysis, it's not likely that we're going to be advocating for them to go on home therapy at all. So those are some of the factors that we also consider. And then those people that have been on immunosuppression for their kidney problem, maybe they've had some kidney problem, they require immunosuppression, chemotherapy, and all that, we look at them because the risk of infection is higher. So we also consider their setting. So those are some of the factors that we look at, say, now, what is best for you as an
Yeah.
individual, considering all your own social, medical, family circumstances, what is best for you. So those are some of the decisions we also help the patient to make because
Yeah.
we are the one looking at the whole picture.
Okay.
So I just wanted to bring it up before we finish
Yeah.
so I don't forget
Yeah.
it. And then the last aspect, which is very important, is the effect of dialysis, the psychosocial effect of dialysis, of starting dialysis. A lot of time when people hear about that, they go into denial phase. You have to really get involved from day
Yes.
one.
Yeah.
But if you don't get involved, you lose out in so many things, and it's something that is life transforming. So
Yeah.
you have to be involved. When they tell you that, okay, this is where we are, don't say, oh, it is not my portion, or God forbid, or those kind of. You just have to accept it and start understanding the because you might not be in there for 1 year and you will have lost the opportunity you had. So it's very important that we have to get ourselves into that, being
Yeah.
able to accept those things when they come and engaging with our specialists so that they are there to help you to support you all through.
Exactly.
People may be
Yeah.
depressed because of that. So depression is something that's quite common, or they will be anxious. How am I going to get through this? Body image, social support, non-compliance. So those are some of, and then financial implication. We need to talk about this because a lot of time we don't discuss it when we see our patient because it impacts on your travel, your holidays, getting insurance. These are things that affect you.
Oh, yes.
Getting mortgages. So these are some of the things that are very, very deep seated. And a lot of people are non-compliant, not because of or because of other things, financial issues. So it's also important that discuss some of this with you, especially they will have a way of supporting at least advice. It's not that we're not financial advisors, but
Yeah.
at least understand where you're coming from. We know that these are some of the things you're facing. And if there's anything we can do, we signpost you to where you can get support.
Yeah. Yeah.
Yeah.
Yes, and you just mentioned something earlier on about patients getting involved, and that is an issue that I know that we face, because sometimes we get referred patients who decide that they don't want to go for treatment and they're waiting on God to heal them. So, for those patients who don't want to go on dialysis, are there any alternatives apart from they're going to wait for God to save them? Are there any other alternatives to dialysis apart from transplant first?
No,
No. Okay.
when you get to end stage renal disease, why it's called end stage is that at that level you cannot maintain life without having some form of renal replacement therapy.
Yeah.
So where it is because we have some patients that they've decided not to go on dialysis, not because they don't want to, but because they feel that okay, I've lived a good life. I'm 92. I don't want to my quality of life and not they've made that decision based on their own quality of life, not because they think that there's something will happen, but they've
Yeah.
made a decision considering their own circumstances. You know what? Instead of me to be coming in here 3 times a week, I'd rather just have lived a good life for 95. So I want to
Yeah.
just so those are what we call conservative management, but those are the ones you manage when they're approaching death because their death is probably sooner than they expect. So those are the ones we have a different pathway for them. They get involved in palliative care. But
Okay.
the one we are talking about, people that are denying
Yeah.
the fact. So
Treatment.
those
Yes.
ones you have to because if you don't get that, you're not going to survive long and it's not anybody's making. So you're making a decision not to treat yourself, which is what it is. So, and
Yes.
of course, the God has created the physician, the specialist to help mankind. So they are the ones that are giving the knowledge
Yeah.
for people to do what they are doing. So having dialysis or transplant is not has not stopped you from serving God, if that is, if I have to put it across to
Yeah.
whoever is, okay, this might make me less of what I believe. But
Yeah.
I think that it wouldn't also be good if you don't take care of yourself. Because we
Okay.
also have to love our body. And part of loving your body is actually making sure you do the right thing for your body. And that is getting the right treatment for your body.
Yeah. Okay. Okay, thank you very, very much.
Yeah.
That was our last question. Do you have any last words for anybody who is currently waiting, waiting to go on dialysis? Do you have any last words for them before we finish?
So the what I will say to you is just be calm. Don't be anxious. Don't worry about how this is going to. It might be very overwhelming at the beginning. There'll be a lot of things that you cannot take in, but just it's a journey, and that journey is you're part of that journey. And don't exclude yourself in that journey. Make sure that you are the center of the journey. Involve yourself in every decision that you're making. The doctors, the nurses are there to help you, to support you. So don't isolate yourself from that. You are the center of the whole process. So what I would advise anyone at that level is just make yourself available. If you don't understand anything, make sure you ask question, ask and ask. Don't be afraid of okay, I don't want to ask. That we're there to help. Anything you're not clear about. If you have any issues, get in touch with your doctor, your nurses that they already know you, so they should be able to give you enough advice. And I
Yeah.
can tell you, the more you get through it, you find out that it's not as bad as you thought it is.
No,
We
definitely not.
have had patients that have lived on dialysis for 25 years, so
Oh,
it's
yeah.
something that can be done. So don't think that oh, this is the end of the world. No, it
Yeah.
is not. You have
Yeah.
different options. So
Yeah.
just want to encourage you to make sure you get involved, engage yourself, be positive about it, and just expect the best.
Oh,
And we're
thank you,
there to help. Yeah.
thank you very much. I really appreciate that. So, everybody, we've come to the end of the session. We just want to thank Mr. Chris Agbo for coming on to talk to us about the different dialysis options and other things as well. And this is the way we want our communities to actually start engaging Because when you attend these sessions, if you have questions, if you're not sure about, what to do, you've been diagnosed or a family member has been diagnosed, you don't have to sit at home thinking there is no hope, there's nobody I can go to. There is somebody. Our charity, WSH Kidney Network, was set up to look after kidney patients in the BME community. So whether you're Black, you're Asian, or from the underrepresented groups of the Asian and Black communities, even from the white community, please come ask for that support. We advocate, we advise, we educate, and we also advocate on behalf of kidney patients. So that there is help out there. There is help within the charity. There are people who work with, especially NHS consultants like Mr. Chris Agbo. There is the information there. Attend the education sessions, contact us, and we'll be very, very happy to work with you. So thank you very much. I think earlier last week I was talking about at people attending the session, and we will tell you so one of our projects that's coming very soon that rhymes with living. So our next project, big project, which is going to run from September, is the living donation project. So we will be talking about living donation. If you are a kidney patient who is waiting to go on dialysis and you think you want to explore the living donation arena, or you need to speak to somebody about living donation, we're working with Salford Royal NHS Trust. We're working with them and we're speaking to doctors. So if you want that support, they do have a one-stop shop. But if you are from the BME community and you want somebody to support you through that process, we're here to support you. If you are looking for living donors, we would feature you on our platform, on this particular platform, where you're going to talk about, what you're going through, speak from your heart to people in the community. So this is a project, it's a pet project, because I believe living donation is one of the best ways to go forward. Okay, working with your family, working with your neighbors, working with your friends. There are different types. So I'm going to bring different nephrologists, bring them on to talk about living donation, the different areas of living donation. We're going to have patients who are waiting for donation if they will come on. We have patients even in the States who are looking for living donation. So keep attending our sessions. Next month we have Dr. Joyce Popola, who is going to come and talk about the issues that young kidney patients face. So keep a date. If you know any young person who is a kidney patient and would benefit from that session, please, when the link goes out, please share them with your young people. Encourage them to come and ask questions. These things are done because we feel that we don't get enough information, before we become kidney patient. That is why we do this. Okay, so thank you everybody for staying with us today. And until next month, when we bring Dr. Joyce Popola onto this platform, thank you. We want to thank Mr. Chris Agbo again for coming on. Thank you so much, Chris. That was a really educative session. And I hope that people who are watching the replay would be happy to come on again next month to listen to Joyce speak about kidney disease amongst young people. Thank you, everybody, and have a wonderful evening. Thank you very much, Chris.
Bye.
Bye. And it's me again, Hilary Asumu. Thank you for being here. Bye.